Welcome to another episode from the Veterinary Medicine Digest. Today, we dive into one of the most frustrating and historically devastating diagnoses in feline practice, feline infectious peritonitis, universally known as FIP. This systemic inflammatory disease, caused by infection with feline coronavirus, often carried a grim prognosis. For decades, the mortality rate for cats who developed feline infectious peritonitis was historically near 100%, with most succumbing within weeks to months of diagnosis. However, recent leaps in scientific understanding, combined with revolutionary advances in therapeutic options, specifically the introduction of direct antiviral treatments, have fundamentally transformed feline infectious peritonitis from a death sentence into a highly manageable, often curable condition. Feline infectious peritonitis is unique and puzzling because while infection with the causative agent, feline coronavirus, is incredibly common and ubiquitous in cat populations worldwide, the ensuing life-threatening disease itself is not. Feline coronavirus is an enveloped, positive-sense single-stranded ribonucleic acid virus, classified as a Group 1 alpha coronavirus, closely related to canine enteric coronavirus. It is prevalent globally, particularly in high-density multi-cat settings such as breeding catteries and shelters, where prevalence rates can approach 90%. The virus typically spreads via the fecal-oral route, frequently involving contaminated litter trays and communal feeding or housing areas. Most feline coronavirus infections result in asymptomatic illness or a mild, self-resolving enteric disease, sometimes manifesting as mild diarrhea. The defining mystery of this disease lies in the shift in the virus's pathogenicity. The prevailing, internal mutation, hypothesis suggests that the highly virulent form of the virus, known as feline infectious peritonitis virus, arises from the relatively innocuous feline coronavirus, often dubbed the good twin, through spontaneous mutations occurring within an individual infected cat. These acquired mutations convert the benign virus into a virulent, lethal form, the evil twin, enabling systemic spread. This fatal conversion is marked by a critical alteration in the virus's cellular tropism. Initially, the virus replicates primarily in intestinal epithelial cells, consistent with its enteric nature. The feline infectious peritonitis virus mutant acquires the ability to efficiently enter and replicate within monocytes and macrophages, thereby facilitating its systemic spread throughout the cat's body. This acquisition of macrophage tropism is considered a pivotal step in the development of feline infectious peritonitis. Intriguingly, as the efficiency of replication in monocytes and macrophages increases, the virus's ability to replicate in enterocytes decreases. This change in tropism often results in the feline infectious peritonitis virus being either not shed or shed only at very low levels in feces, which is why feline infectious peritonitis epidemics are uncommon, unlike those caused by other highly contagious feline pathogens. Researchers have extensively studied which parts of the large feline coronavirus ribonucleic acid genome are responsible for this switch in virulence. Key candidates include the spike envelope glycoprotein gene, or S gene, which is crucial for attachment and entry into the host cell, and the accessory protein genes, specifically the 3C and 7B open reading frames. The spike protein consists of two subunits, S1, responsible for host receptor recognition, and S2, required for membrane fusion. Mutations found in the spike protein gene, such as amino acid changes, e.g., M1058L and S1060A, within the fusion region, have been identified and hypothesized to enable efficient replication in monocytes and macrophages. Additionally, structural alterations in the proteolytic enzyme furin family recognition site, the S1, S2 cleavage site, of the spike protein are considered critical for the development of virulence. However, this diagnostic search is complex. Testing solely for the spike gene mutation is generally considered insufficient to confirm feline infectious peritonitis in all cats, as some healthy cats may carry viruses with these mutations in their blood or tissues, suggesting the mutation might correlate primarily with systemic spread rather than feline infectious peritonitis pathogenesis itself. Furthermore, accessory protein genes play a role. Mutations in the 3C protein gene often lead to truncation, which has been associated with systemic spread of the virus and the loss of the ability to replicate in intestinal epithelial cells. An intact 3C gene is considered necessary for intestinal replication and shedding in feces. Beyond the virus itself, host factors determine susceptibility. Feline infectious peritonitis is overwhelmingly diagnosed in young cats, typically under 2 years of age, with the highest incidence observed in those under 1 year old. Susceptibility frequently follows familial lineages or certain breeding lines, suggesting a strong genetic component, often involving characteristics related to the major histocompatibility complex, the quality of cytokine responses, and features of the cell-mediated immune response. Cats that develop feline infectious peritonitis often mount a robust yet ultimately ineffective humoral antibody response rather than the effective cell-mediated immune response necessary for viral clearance. Environmental stressors such as shelter housing, adoption, recent surgery, like spay or neuter, or subtle changes in social hierarchy, are frequently noted precursors to disease onset, possibly leading to increased glucocorticoid production which negatively impacts cell-mediated immunity. The clinical signs of feline infectious peritonitis are notably varied, making diagnosis profoundly challenging. The disease manifests in two primary, yet overlapping, forms: the effusive form, often called wet FIP, and the non-effusive form, known as dry FIP. The effusive form involves widespread vasculitis leading to fluid accumulation, most frequently seen in the abdominal cavity, ascites, but also possible in the thoracic or pericardial cavities. This form typically follows a relatively rapid course. The fluid associated with feline infectious peritonitis effusions is usually a highly protein-rich, fibrin-rich modified transidate or exudate, typically presenting as viscous, sticky, and straw yellow in color. The non-effusive form involves a more protracted, insidious course, where clinical signs are linked to the specific organs afflicted by pyogranulomatous lesions. Common organs involved include the kidneys, sometimes reno-megaly or small kidney size, liver, spleen, intestines, often manifesting as intestinal thickening or mesenteric lymphadenopathy, eyes, uveitis, and central nervous system, neurological signs. The division into wet and dry forms is primarily descriptive, as pyogranulomatous lesions are frequently found even in cats presenting with the effusive form. Regardless of the form, most affected cats initially present with vague, nonspecific signs, such as lethargy, decreased appetite, anorexia or hyporexia, weight loss or failure to gain weight in kittens, and a fever that is often fluctuating, waxing and waning, and non-responsive to antibiotics. Specific presentations offer diagnostic clues. Ocular FIP frequently manifests as anterior and/or posterior uveitis, with clinical signs including changes in iris color, hyphema, blood in the eye, hypopyon, pus in the eye, keratic precipitates, inflammatory deposits on the cornea, and sometimes retinal detachment. Ocular FIP is reported in up to 36% of cases, sometimes concurrent with neurological disease. Neurological FIP can cause a wide array of signs reflecting the neuroanatomic localization of the lesions, including seizures, abnormal behavior, mentation, ataxia, hyperesthesia, nystagmus, and cranial nerve deficits. Neurological signs carry a poorer prognosis for survival than non-neurological signs. Gastrointestinal FIP can present as a palpable abdominal mass, often enlarged mesenteric lymph nodes or thickening of the intestinal wall, often misidentified as a tumor, and sometimes leads to diarrhea. Critically, intestinal FIP can sometimes lead to protein-losing enteropathy, resulting in low total protein and globulin values, which contrast sharply with the classic FIP presentation of high globulins. Given the lack of definitive clinical signs or pathognomonic routine laboratory changes, accurately diagnosing feline infectious peritonitis requires gathering multiple pieces of evidence, often described as building the diagnostic wall, brick by brick. The definitive and highly specific gold standard for diagnosis remains postmortem histopathology coupled with immunohistochemical staining, IHC, of affected tissues for feline coronavirus antigen. This demonstrates active feline coronavirus replication within macrophages associated with the characteristic pyogranulomatous lesions. Obtaining this gold standard antemortem is invasive and often impractical, necessitating the use of less invasive tests. Several laboratory tests contribute to suspicion. 1. Routine hematology and biochemistry. Common findings include a mild non-regenerative anemia, neutrophilia, and lymphopenia. Lymphopenia is a selective decrease in T lymphocytes and its degree predicts disease progression. Serum biochemistry usually reveals an elevated total protein level, reflecting increased globulins, hyperglobulinemia, and a decreased albumin to globulin ratio, A/G ratio. A serum A/G ratio less than 0.4 is considered highly suggestive of feline infectious peritonitis. Conversely, an A/G ratio greater than 0.8 has a high negative predictive value, helping to rule out the disease when prevalence is low. Hyperbilirubinemia is frequent, often occurring independently of severe hepatic damage, possibly due to increased erythrocyte fragility or inhibited bilirubin transport. Elevated bilirubin levels at diagnosis have been consistently shown to be a poor prognostic sign. Acute phase proteins, particularly alpha-1 acid glycoprotein, AGP, are often markedly elevated. Concentrations typically found in FIP cats often exceed 1.5 mg per milliliter. Monitoring the normalization of AGP has also been suggested as an indicator to stop antiviral treatment, often normalizing faster than globulins. 2. Effusion analysis. If an effusion is present, fluid analysis is extremely informative. The fluid is typically proteinaceous, over 35 grams per liter, and low in cell count, less than 5 × 10 to the 9th power per liter. The Revoltas test offers a rapid and inexpensive in-house screening test. This involves carefully dropping the effusion sample into a weak acetic acid solution. A positive result occurs if the drop precipitates and retains a jellyfish-like shape. While positive results are nonspecific, a negative Revoltas test makes feline infectious peritonitis highly unlikely due to its high negative predictive value, around 93%. Cytology usually shows pyogranulomatous inflammation, macrophages and non-degenerate neutrophils. 3. Molecular testing, RT-PCR, quantitative reverse transcriptase polymerase chain reaction, RT-qPCR, detects feline coronavirus ribonucleic acid in non-intestinal sites like effusions, blood, or tissues. The core challenge is differentiating high levels of actively replicating virulent feline infectious peritonitis virus from low levels of a virulent feline coronavirus, which can also be detected systemically. Finding a significant quantity or high viral load of viral ribonucleic acid outside the gastrointestinal tract strongly supports a highly likely diagnosis of FIP, especially when accompanied by suggestive clinical signs and clinicopathological markers. RT-qPCR results on blood samples often show high FCOV ribonucleic acid loads in cats with FIP. The specific analysis of viral spike gene mutations following a positive RT-PCR result has historically generated inconsistent and variable results across different studies and methods, complicating its reliability as a confirmatory tool. The history of treating feline infectious peritonitis was restricted to palliative care, notably the use of corticosteroids to suppress inflammation, which offered temporary relief but did not alter the fatal outcome. The advent of direct antiviral compounds in recent years fundamentally shifted this paradigm. The precursor to the modern revolution was the development of the 3C-like protease inhibitor known as GC376, which inhibits viral replication by targeting proteases necessary for viral processing. Although early trials showed efficacy in experimental FIP, natural feline infectious peritonitis proved more challenging to treat, showing high relapse rates, especially the neurological form which failed to respond to increased dosage. The breakthrough came with the nucleoside analogues, specifically GS441524 and its prodrug, remdesivir, GS5734. These drugs interfere directly with viral replication by acting as an alternative substrate and ribonucleic acid chain terminator for the viral ribonucleic acid-dependent ribonucleic acid polymerase. Initial studies confirmed that GS441524 was non-toxic in feline cells up to 100 micromolar and effectively inhibited feline infectious peritonitis virus replication at concentrations as low as 1 micromolar. Pharmacokinetic studies demonstrated that an injectable dosage of 5 mg per kilogram sustained effective plasma concentrations over a 24-hour period. Importantly, drug concentrations achieved in the ocular aqueous humor and cerebrospinal fluid were consistently lower, about 1/5 of the plasma levels, explaining why higher doses are needed for complicated FIP forms. The pivotal field trial treated 31 cats with naturally acquired feline infectious peritonitis. Cats initially received 2 mg per kilogram subcutaneously once daily for a minimum of 12 weeks. Clinical response was rapid. Fever resolved within 12 to 36 hours, and effusions dissipated within 1 to 2 weeks. 18 of the 26 cats who completed the full 12 weeks remained healthy. 8 cats relapsed, leading to the conclusion that 4 mg per kilogram subcutaneously once daily for at least 12 weeks provided a superior and more reliable outcome, achieving a sustained remission in 25 of the 26 cats, representing a 96% survival rate for those surviving the initial 48 hours of treatment. Since then, efficacy has been confirmed across all clinical presentations. Cats with neurological and/or ocular manifestations often require significantly higher dosages, typically ranging from 15 to 20 mg per kilogram daily, administered for at least 12 weeks. This dose escalation is necessary to ensure the drug adequately penetrates the blood-brain and blood-eye barriers. One recent observational study found that feline infectious peritonitis-associated uveitis responded effectively to remdesivir or GS441524 treatment in 82% of cases. The effective use of GS441524 is now moving towards oral formulations, often 50 mg tablets, primarily to address the severe injection site pain associated with subcutaneous administration. The subcutaneous route, while effective, often caused vocalization, growling, and skin reactions. Oral administration greatly improved owner and patient compliance. Remdesivir, the prodrug, is often administered intravenously or subcutaneously, typically in a sequential therapy regime, starting with remdesivir to achieve rapid circulating levels in severely ill cats, followed by oral GS441524 for maintenance. Recent studies using legally sourced veterinary compounded preparations demonstrate high success rates, around 84 to 96% survival, dependent on the cohort, with both remdesivir alone or sequential treatment. Molnupiravir is another oral nucleoside analog showing similar efficacy and safety profiles to GS441524. It has also been successfully used as a rescue treatment for cats that failed or relapsed following GS441524 therapy, suggesting its importance as an alternative antiviral to manage potential resistance. Monitoring treatment efficacy involves tracking clinical and laboratory parameters. Fever resolution and effusion dissipation are rapid clinical indicators. Laboratory parameters track normalization over a longer period. Packed cell volume and absolute lymphocyte count normalize early, while mean serum globulin concentrations and the albumin to globulin ratio take longer, generally taking around 8 to 12 weeks to approach normal levels. Due to the historical time required for these markers to normalize, a minimum treatment period of 12 weeks, 84 days, was initially established as the standard duration. However, this conventional duration is now being rigorously questioned. A highly significant recent prospective randomized controlled study compared 42 days, 6 weeks, of oral GS441524 treatment, at 15 mg per kilogram daily, to the traditional 84 days in cats presenting with effusive feline infectious peritonitis. This groundbreaking study found that the shorter duration resulted in equal efficacy for achieving sustained complete remission, with 95% survival across both groups. The shorter course significantly cleared viral ribonucleic acid loads in the blood, undetectable by 28 days in all cats. This finding is crucial as it suggests a much shorter treatment duration may be adequate for stable cats with effusive disease, potentially reducing costs and associated stress for the animal and owner. Adverse effects associated with nucleoside analog treatment are generally mild. The most common clinical adverse effect reported is the severe injection site pain accompanying subcutaneous administration of GS441524 or remdesivir. The most common clinicopathological adverse effects observed are transient increases in liver enzyme activity, ALT, in up to 30% of cats receiving GS441524, and transient eosinophilia, neither of which typically required stopping treatment and often resolved spontaneously. The collective evidence confirms that feline infectious peritonitis is now a highly treatable disease, with high success rates across varied clinical presentations. The immediate future of feline infectious peritonitis management involves refining protocols, determining the minimum effective duration, e.g., whether 42 days suffices for all cases, optimizing dosages for the challenging neurological forms, where 20 mg per kilogram daily is often needed, and ensuring broad, legal access to quality-controlled antiviral medications worldwide. Thank you for listening. The titles for the referenced papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.